Hi, everyone. Welcome back to another full code case walkthrough. Today, we're going to be doing case number 43, a patient who presents with a rash and fatigue. This is a patient who walked into the emergency department and they're placed into one of our low acuity rooms. She's a 32-year-old woman presenting with a leg rash, no fever as noted at triage, and she's had no reported sick contacts. With that, we can begin the case. What we first want to do is, in this low acuity room, put the patient on the monitor to just get an initial set of vital signs. Here we can see that her vital signs are reassuring. She's got a normal heart rate and blood pressure. She's afebrile currently, and she has a normal oxygen saturation and respiratory rate. So with that, we don't need to initiate any stabilizing maneuvers. We can begin in taking a history and physical. So this 32-year-old female is complaining of a rash on the back of her leg. It started 3 days ago and has progressively increased in size. There's no pain and no itching. She has not tried any of the over-the-counter remedies available. She has no new soaps or detergents. She's concerned about maybe it being poison ivy because she was hiking in the woods in shorts. She's working currently as a camp counselor in the Northeast, in Maine in this case. And the last time she had poison ivy, she remembers intense itching, which is not similar to what she's presenting with today. She's been feeling very fatigued over the past 2 days as well. She has a history of hypothyroidism and mild asthma. Her medications include Synthroid and albuterol, only used on an as-needed basis. She has an allergy to penicillin, which causes hives. Her family history is relatively unremarkable: hypothyroidism in her mother and hypertension in her father. In terms of social history, she lives with a roommate, works at a local restaurant as a chef and camp counselor on weekends during the summer. Social alcohol use, no tobacco, no injection drug use. And so in this case, since her vital signs are remaining stable, we can proceed with taking a little bit more history and going through her review of systems. Given that she has a rash and fatigue, we certainly want to ask about any constitutional symptoms. She feels tired, but there's no weight loss that's unintentional. She has a slightly diminished appetite, but denies any fever. We want to ask about any eye symptoms such as conjunctival redness. She doesn't have any of that. She has no runny nose or symptoms otherwise suggestive of an upper respiratory infection. She has no chest pain or shortness of breath, no exercise intolerance that's accompanying her general sense of fatigue. And she has no reported leg swelling that we might find in cases where a patient has new onset renal failure or congestive heart failure. From a respiratory standpoint, we want to ask historical features that would suggest maybe a pneumonia. There's no coughing, wheezing, hemoptysis, no significant shortness of breath or sputum production. Certainly with hiking in the woods, we'd also want to ask about any GI symptoms that might suggest contact with something like Giardia. And so she has indeed no abdominal pain, no diarrhea, no nausea or vomiting, and otherwise has an unremarkable history there. It's reasonable to ask about genitourinary symptoms, in particular any symptoms concerning for a urinary tract infection, which can present with fatigue. She does not have any complaints of dysuria, hematuria. And lastly, we want to ask a little bit about her skin. So she complains of this circular rash on the posterior right leg. There's no accompanying itching, pain, or drainage. And usually in a patient complaining of fatigue, I will ask about any evidence, any history of joint discomfort or swelling that might suggest an autoimmune phenomenon. And indeed, she does not complain of any arthralgias nor myalgias. She does report a history of an allergy to penicillins and does have a history of asthma. So I'd want to ask about any other allergic symptoms that she might be having as well. She does not have any history of significant allergic reactions and currently doesn't have any symptoms that would be consistent with an acute allergic reaction. So we can now proceed on to the physical exam. I'm not too concerned about her airway, breathing, or circulation, so I think we can move on to look for localized sources of infection. On HENT exam, her oropharynx is clear. On neck exam, her neck is supple. She's got good range of motion. On cardiac exam, just looking for any evidence of congestive heart failure or dysrhythmia. She does not have any. And as we can see on her monitor, she's in a regular rhythm. I want to listen to her lungs to make sure that there's no focal lung sounds. Perform a quick abdominal exam to ensure there's no tenderness. And then in terms of her musculoskeletal exam, looking for any signs of limited range of motion or focal joint pain. And on skin exam, I would want to take a look at this rash. And so in the lower posterior right thigh, she has a 8-centimeter area of a circular rash with central erythema and surrounding clearing. And here we can see an image of the rash. This rash is relatively consistent with something called Erythema chronicum migrans, otherwise described as a targetoid rash, and it's singular, and we note that there's no pain, as we might see with something like erythema nodosum, which typically is more swelling than a localized rash, but can present with overlying redness. And in addition, there's not a lot of discomfort that would suggest this being a cellulitis or a localized skin infection. So, in terms of stabilizations, there's not much in terms of stabilizations that we would need to do given her reassuring vital signs. I think in terms of her location, being in the Northeast and exposure to the woods and potential for tick-borne illness, I would think about Lyme disease, obviously, as one of the kind of initial ideas as to why she might be having this rash. So I'm going to select Lyme disease as a possibility. I don't think that this is measles. The rash is not consistent with that, and she doesn't have any other systemic symptoms. And as we scroll down the list here, a lot of these other choices wouldn't be appropriate given that she doesn't have any associated symptoms. We can take a look and see. In terms of dermatologically, we can put cellulitis on the differential. That would be very reasonable. And then in terms of investigations, early signs and symptoms of Lyme disease can occur within 3 to 30 days after a tick bite. And they're usually accompanied with fatigue, sometimes myalgias, headache, even fever and chills. About 80% of patients with Lyme disease develop erythema migrans, which this patient is presenting with. And typically, this is a target lesion or bullseye appearance. The lesion occurs at the site of the bite and usually expands and can be as large as 30 centimeters in diameter, so it can be quite large and progressive. The diagnosis of Lyme disease can be based on the characteristic rash alone in association with tick exposure in an endemic area. So in many cases, careful monitoring where you have a case of uncertainty around an area that doesn't look exactly like the targetoid lesion as we're kind of showing here. You can observe them for 2 or 3 days and see if the rash progresses. However, I think based on this rash, it's reasonable to diagnose her with Lyme disease based on the clinical history and physical exam alone. In terms of investigations, there are some testing things that we can do. A lot of the basic labs that we obtain in the ED are not applicable, but I think it would be reasonable to send a Lyme test on her. This would be mostly for confirmatory testing. I don't think this would change my management of the patient at this time. So the lab receives the sample. The testing won't come back in time for us to have it play a significant role in terms of our decision-making regarding treating the patient. Treatment and disposition of this patient depends on the particular presentation. In this case, she's stable. She has a rash. She doesn't have a lot of systemic symptoms associated with it. So I would presume that doxycycline, which is the typical agent of choice, would be inappropriate. However, doxycycline is contraindicated in children younger than 8 years of age and also in pregnant women, in which case we would use amoxicillin or cefuroxime. Now, this patient has a history of allergy to penicillins, and although cefuroxime is likely safe to use, given that allergies to penicillins are not necessarily associated with allergies to cephalosporins, it would be reasonable at this point in time to also send a urine HCG, and so we can send that. And after confirming that the patient is indeed not pregnant, even if she were unaware of it and the early stages of pregnancy, it would be safe to then treat her with doxycycline. So we can do that. And so I'll go under my list here, and under antibiotics, we'll select doxycycline and give her that. In terms of communications, there's no reason to consult with infectious disease or anybody else at this point in time, but we would want her to follow up with primary care or return for any worsening or concerning symptoms if her symptoms do indeed progress. Typically, patients recover within a few weeks of initiating antibiotic treatment, but a small percentage of patients will develop post-treatment Lyme disease syndrome, and that's a condition in which symptoms including fatigue and myalgias can last for more than 6 months. Studies have shown that prolonged antibiotic administration does not expedite resolution of this particular syndrome. So at this point in time, I think we can diagnose her with Lyme disease, and I think that she would be safe for discharge. In this case, I would treat her with a 21-day course of doxycycline and have her return for any worsening or concerning symptoms that would suggest ongoing or progressive disease, especially involving the heart, which can lead to conduction blocks and dysrhythmias, as well as any CNS involvement, which may present with cranial nerve abnormalities. As with every case, we provide you with the correct diagnosis and disposition, as well as feedback on individual actions as far as review of systems, physical exam, investigations, interventions. In this case, we did just fine. In all cases, we provide you with a thorough, detailed discussion. And in here, you'll find the approach to the case, the recommended treatments, the various pitfalls that I had mentioned during the presentation, and we also include essential references for further reading. That's all for this case, and we'll see you in the next walkthrough video.